So let's turn our attention to some cases, because I think cases are instructive. They help to allow people to hear about the panel's thought processes when they think about patients that are presenting to them in the office. So let's start with our first case, which is a 66-year-old male who presents with a right kidney mass discovered during a workup for right hip pain. And this patient, not untypical, had no hematuria. Past medical history is for well-controlled hypertension, hypercholesterolemia with no cardiac history, 20-pack-year smoker, negative family history, physical examination showing some right flank fullness, otherwise normal exam, performance status of 1 using ECOG criteria, 80% using KPS, with some mild fatigue and anorexia, a hemoglobin of 11, a creatinine of 1.2, an LDH of 287, and a normal calcium. So let's assume, Brian, for at least this first portion of this patient, that he has a primary tumor in place and a solitary bone met. And the solitary bone met is in a non-weight-bearing area of his hip. How do you approach this patient?
So for that kind of patient, I mean, I guess to more broadly talk about debulking nephrectomy, that patient obviously has the bulk of their disease in the primary. I guess no primary symptoms, but with a reasonable performance status, our institutional bias, my personal bias, is for debulking nephrectomy up front for both diagnostic and therapeutic reasons. If after that we restage and it's still a solitary bone met, then we would think about focused radiation to that bone met.
So Danny, oligometastatic disease, post-nephrectomy, localized radiation therapy for control, restaging, NED. What do you do?
So if it's NED, that's exactly the situation you want, because there is a chance, although it's not a very high chance, that we could have long-term control. And so if someone's NED, I tend to just watch them very carefully with repeat CT scans, and I don't start any targeted therapy yet. It does afford the patient a good amount of time of off toxicity, and so I would wait until there's more disease, until there's disease progression before starting any targeted therapy.
And Chuck, would you put a person like that on a bisphosphonate?
In clinical practice, I would, for a number of reasons, but I agree I wouldn't start a TKI at that point.
So, John?
Just to mention, if suppose the solitary met was something that could be resected, so they were resected to NED, there is an intergroup trial available which is pazopanib versus placebo, because in that setting the standard of care would be to observe.
So I think that we would all agree that oligometastatic disease may be a unusual but not totally uncommon disease that we need to be aware of, that we need to approach the oligometastatic disease appropriately and not jump into systemic therapy unless otherwise necessary. So let's assume that the patient's different, and rather than a single bony met, Brian has multiple bony mets. None in weight-bearing areas, none that need surgical attention, none that are really causing much in the way of symptoms other than some mild pain relief. What's your decision-making process about starting therapy in that patient?
I mean, I think like all patients, it depends on extent of disease. Maybe histology, maybe trials that we have open, sort of opportunities for more exciting therapy. We do have data about observing patients. I have to say, bone disease tends to be more aggressive in kidney cancer, so I'm not sure that I've observed a patient with bone-only disease. I've certainly observed patients who have lung nodules and then a little tiny bone, something that's maybe been radiated or not. So, but with bone predominant or bone-only disease, it tends to be more aggressive. I'd probably be more likely to start that patient on systemic therapy.
And Jan, bone-only patients with IL-2, can they still benefit?
There is benefit in bone-only patients and in patients with liver mets. It's perhaps not to the degree of lung nodule patients, but if it was a person with no comorbidities and otherwise healthy, I would certainly offer it as an option, as an attempt, and see what happens. And I would also, with multiple bone mets, would start bisphosphonate.
So let's assume that we start this patient on a TKI, and for the purposes of today's discussion, we'll start them on standard dosing sunitinib, 50 milligrams, 4 weeks on, 2 weeks off. Patient comes back 12 weeks later, a bit more tired. some soreness in the hands, but not debilitating. Some mild mouth sores that have been easily managed. Hypertension that got a little bit worse that's easily controlled. Danny, any change in your schedule and course with those side effect profile?
Sure. So I usually, someone usually contacts the patient at 1 week just to make sure that they're okay. And I usually see them at 2 weeks, actually, to be honest, just to make sure that they're tolerating the drug well. And then I see them at 6-weekly intervals. So if they have less than grade 2 toxicities, just minor grade 1s here and there, and it's fairly tolerable and not a bad knock on their quality of life, then I would proceed. But if there are more grade 2 toxicities and it's starting to impact a lot on their quality of life, then I would consider potentially switching the schedule to 50 milligrams, 2 weeks on, 1 week off.
So, Chuck, there's some low risk of cardiac abnormalities with these TKIs. Does that influence what you do, how you follow them? Do you ever do MUGAs on these patients? Do you ever have a cardiologist follow up with them? What's your bar for worrying about that cardiac toxicity from the TKIs?
I warn patients about it, and I control their hypertension very aggressively, but generally that's all I do. I don't do MUGAs or echoes routinely.
So Brian, Jan, anything different?
No, I don't do MUGAs or echoes routinely or EKGs. We have a great cardiology department at Cleveland Clinic, so we will often, for the more difficult to control hypertension, send them for a visit or two just to kind of get on track, make sure we're doing the right thing, although we're fairly comfortable doing it. A lot of times it's just helpful oversight to get them on track, and then we manage from there.
And do you ever, a person who comes in, not necessarily this person, but with an extensive cardiac history and metastatic kidney cancer, do you, Jan, think about your choices and are careful about your approach?
If they have a history, I'm more concerned, yes, because I have seen people decompensate that had compensated cardiac, mild cardiac failure, decompensate with any of the anti-VEGF drugs. So those patients, I might try another approach.
And Danny, one question just to be clear for our viewer. Suppose this patient came back on sunitinib with elevated liver function tests 4 weeks after starting, and let's say they were 10 times the upper limit of normal. Is pazopanib an option after they recover from their liver dysfunction?
I'd be very worried about switching to pazopanib. Pazopanib actually has a much higher incidence of LFT abnormalities and liver dysfunction. So in that sort of patient, I would check to make sure there are not other causes of liver disease, Tylenol, hepatitis, for example, but they would probably have to stop the targeted therapy and move on to something else.
So Jan, imagine you're having a conversation with this patient, and it's at the beginning of the course. Nephrectomy, radiation for bone, started on sunitinib at some point. How do you have the conversation about his prognosis? What do you tell this person?
What I tell a patient, if we've decided that they're going to be going on TKIs, that our goal is going to be keeping them stable for as long as possible. And I may not say you're in this category, but I can give them from the research the expected median time. And I say some people are longer, some people are shorter. We're going to have to, I try to put it in as positive a light as possible, but realistic, that we have to see how things go with you and how your course is going to be. And that's about where I leave it, frankly.